we're happy and privileged to have Professor Maria-Gloria Basáñez, who's at the School of Public Health from the Imperial College London, and she's going to give a talk on the alternative and complementary treatment strategies for neglected tropical diseases. And Maria-Gloria is also the chair in neglected tropical diseases at the Imperial College London, and she studied medical entomology and parasitology at the Liverpool School of Tropical Medicine, and also mathematical epidemiology at Imperial College. So we're going to spend the next 45 minutes listening to Maria-Gloria, and then we'll finish it off with questions and discussion. So over to you.
Okay, thank you, Mutono. So you can hear me okay?
Yes.
All right, so I'm going to minimize this. And okay, so welcome all. Thank you for the invitation. So my talk today is about alternative and complementary treatment strategies for neglected tropical diseases. I'm going to cover a number of them. So the outline of this talk will be that I will introduce what the neglected tropical diseases are. Some of you might be aware, some of you may not be so familiar with them. Then the second 2021 to 2030 World Health Organization roadmap on NTDs. Because that roadmap talks about control, elimination as a public health problem, elimination of transmission and eradication, I'm going to introduce those terms. I'm going to also discuss the role of modeling, mathematical modeling, in informing the WHO roadmap for NTD control and elimination. And particularly, I'll focus on the contribution of our groups at Imperial College, particularly my group, because Imperial College also contributed to other NTDs. But I'm going to focus on Chagas disease, Taenia solium, taeniasis, cysticercosis, and onchocerciasis. We'll finish with some take-home messages, hopefully in time for a discussion. So what are the neglected tropical diseases? So this is really an umbrella term. This term encompasses a diverse group of mostly communicable diseases of poverty, but they exclude malaria, HIV, and tuberculosis. The term neglected tropical diseases, NTDs, was coined against the background of these three diseases, which are called the so-called the big three, to raise their profile and to unite efforts against this range of tropical, subtropical infections and conditions. So we can trace back the origin of the term NTDs to the year 2000, when it accompanied the launch of the Millennium Development Goals. We know now we call about Sustainable Development Goals. But at that time, the Millennium Development Goals were launched in the year 2000. The movement of NTDs also started. And the idea was to bring together a cohesive group of diseases that we had a joint or have a joint burden, this burden, which would be, if jointly taken into account, comparable to any of these big three. Now, according to the World Health Organization latest list of NTDs, 20 of them have been currently recognized and prioritized. That doesn't mean that there are only 20 NTDs, but 20 NTDs have been recognized by the WHO. And they range from viral and bacterial infections to fungal and protozoan, and also include metazoan infections. Snake bite envenoming is also included. It's not truly a communicable NTD. The distribution is in tropical and subtropical areas of at least 149 countries, and it affects more than 1 billion people, actually about 1.45 billion, and cost these developing economies billions of dollars every year. So the roadmap on NTDs for 2021-2030 follows a first roadmap that was launched in 2012 and was going to cover the period of 2012 to 2020. And that first roadmap also accompanied the London Declaration on NTDs. But the goals were then revised, and there was a process of consultation on which I will abound a bit later. I think the most important thing about this roadmap, it has 3 pillars. The pillar 1 is accelerate programmatic action. How can we accelerate reaching the goals proposed in the roadmap? A pillar 2, which is intensified cross-cutting approaches. And that cross-cutting approaches could be intersectoral collaboration, it could be bringing One Health approaches, but also it could bring multidisciplinary approaches. And the pillar 3, which is very important, is to enhance country ownership of these programs. And that is the link to this roadmap. So what are the 20 NTDs that have been currently recognized? So we very recently, part of the London Centre for Neglected Tropical Disease Research, we published a collection of papers in the Philosophical Transactions of the Royal Society in the Biological Sciences Series B. And the introductory paper discusses what the NTDs are and what is the progress that has been made 10 years from the London Declaration in 2012 to 2022, 2023. So you can see these terms here: eradication, for which yaws, dracunculiasis, guinea worm are earmarked. Elimination as a public health problem. We have rabies, which is viral, trachoma, which is bacterial, American trypanosomiasis, Chagas disease, which is protozoan. Also, human African trypanosomiasis of the rhodesiense type is more zoonotic. Visceral leishmaniasis, schistosomiasis, soil-transmitted helminthiasis, and lymphatic filariasis. But for elimination of transmission, interruption of transmission, we have leprosy, which is also bacterial, Gambiense, human African trypanosomiasis, which is anthroponotic, and onchocerciasis. And for control, we have dengue, Boruli ulcer, mycetoma. I mean, these are all fungal infections, chromoblastomycosis and other deep mycosis, cutaneous leishmaniasis, and then some cestode infections like Echinococcus and Taenia, or the trematodes, foodborne trematodes, scabies and other ectoparasitic infections, and snake bite envenoming. The WHO classification for NTDs broadly classifies these into 2 types: the so-called IDM diseases and the PC diseases. The IDM stands for Innovative and Intensified Disease Management. And you can see here some examples. The important thing is that for these diseases, medicines, safe medicines for mass drug administration, for large-scale administration, and cost-effective interventions at large scale are limited. So the main aim is the detection and often prolonged treatment and the management of identified cases. A problem with this is that access to diagnosis and access to treatment needs to be enhanced. And these diseases need to be managed within healthcare systems and ultimately to eliminate them as a public health problem. So we need to intensify disease management with existing tools, but also encourage research and development of better diagnostic and therapeutic tools. For example, therapeutic tools that may require less prolonged treatment courses, to ensure the involvement of national control programs, and in particular, the strengthening of health systems, and advocate for this health service deployment in affected areas. Whereas the preventive chemotherapy diseases, PC, are those for which safe or relatively safe, there have been clinical trials on this, of course, and effective drugs exist that can be delivered in mass drug administration programs with high coverage. And sometimes these involve once per year, twice per year, perhaps more often, but these MDA programs, by and large, can tackle these diseases: soil-transmitted helminthasis, schistosomiasis, onchocerciasis, lymphatic filariasis, and also trachoma. So it's feasible to implement large-scale preventive chemotherapy programs. And the aim here is to provide national programs with technical guidelines, which are updated regularly, so coordinated and cost-effective approaches for implementing these MDA programs can be achieved. And obviously, not only is the implementation phase, but also the monitoring and evaluation. So the objectives here then is to develop technical guidelines for monitoring and evaluation, for transmission assessment surveys, for stop MDA surveys. In the case of onchocerciasis, transmission assessment surveys are mostly related to lymphatic filariasis, for instance, and to build capacity through the development of training tools, workshops for community drug distributors, because many of these programs are implemented in community-directed approaches, and also advocate for integrated approaches if that is possible. So more than one disease can be tackled. And also the building of new partnerships and the expanding of existing partnerships. So the NTDs target for elimination of transmission and elimination as a public health problem, for instance, include here, for example, elimination of transmission, we already mentioned, human African trypanosomiasis of the Gambiense type, leprosy, and onchocerciasis. So I have circled here the ones I'm going to focus on. So here, for instance, there are indicators for each one of these diseases. The indicator for onchocerciasis is a number of countries verified for interruption of transmission. Now, this verification really implies that the country submits a dossier to the WHO with all the documentation, and then there is a visit by experts in the country that can verify that interruption of transmission has been achieved. So it's a process. When we say verification, it's not just having conducted stop MDA surveys, but also having conducted post-treatment surveillance, and in some cases, maybe post-elimination surveillance. So although for 2030, you can say that the target is relatively modest for 12 countries, which is approximately a third of endemic countries, still we need to bear in mind that the whole of the country has to be verified. For Chagas disease, now we have elimination as a public health problem. In this case, we have a number of countries achieving interruption of transmission, but through the various transmission routes. Now, these transmission routes in Chagas disease are many, because yes, it's a vector-borne disease, so we have vectorial transmission, but you could also have a blood transfusion and get Chagas disease, organ transplantation. There is also congenital transmission. And there is another route not even mentioned here, which is oral transmission with food items and drinks contaminated with vector feces. So it's not even mentioned here. And another goal here is to have 75% of antiparasitic treatment coverage of eligible cases. Now, these eligible cases in case of Chagas disease is mainly for acute Chagas and for mothers and for babies. So it's to prevent congenital transmission. But I'm going to tell you later that potentially this treatment should be expanded to be able to provide aetiological treatment. And the goal here for 2030 is to have a little bit more than a third of the endemic countries having achieved interruption of transmission by these routes. So although it's not total elimination of transmission, because with this coverage that is going to be not possible, we would like to interrupt transmission by some or all of these routes. So for control here, we are going to have taeniasis, cysticercosis, which I am going to refer to. And the definition, the indicator here is number of countries with intensified control in hyperendemic areas. So on the one hand, that needs a definition of what intensified control really means and how you classify hyperendemic areas. And in this case, again, it's about a third of endemic countries with intensified control in hyperendemic areas. So what control, elimination, eradication, etc. mean? So when we talk about control, we're talking about a reduction of the disease incidence, the prevalence, morbidity or mortality to a locally acceptable level as a result of deliberate efforts. So that locally acceptable level can be open to interpretation. So you could see, for example, in taeniasis, cysticercosis, we call locally acceptable like intensified control in hyperendemic areas. What about the other endemic areas, for instance? But continued measures would be required to maintain this reduction. Now, when we talk about elimination of disease as a public health problem, we're talking about reducing to zero the incidence of a disease as a public health problem. But what does that mean? So just to give you an example, in lymphatic filariasis, in some cases, in some of the, with some of the vectors, this goal is to achieve less than 1% microfilaria prevalence or less than 2% of antigen prevalence. But does that really mean that we have reduced to zero the incidence of disease, which in lymphatic filariasis refers to, for example, lymphedema and other lymphatic involvements related to this disease? So there is still some lack of understanding or a need for a better understanding of what the thresholds that are proposed in the WHO roadmap really mean for the disease as a public health problem. Elimination or interruption of transmission might be clearer because you want to reduce to zero the incidence of infection that is caused by a specified agent in a defined geographical area. So we can talk about local elimination, and then obviously we need to achieve countrywide elimination, and that is as a result of deliberate intervention efforts. Now, mostly they are targeted at anthropootic infections. Anthroponosis is a term that refers to infections in which the reservoir is the human population. They are not targeted at zoonotic infections because then you have a completely different ball game if you have zoonotic components. But continued surveillance then, post-treatment surveillance and post-elimination surveillance, is necessary to detect the reestablishment of transmission, the resurgence or the reinfection or the importation of infection. When we talk about eradication, we talk about a permanent reduction to zero at worldwide level. And then, for instance, we could say here, well, the world has achieved smallpox eradication, and it has tried also to achieve polio eradication. Polio eradication has not yet succeeded, and intervention measures would no longer be needed. For eradication, for instance, Guinea worm was targeted. And then in some foci, for instance, in Chad, there was transmission with dogs as reservoirs. Not necessarily that was a new phenomenon, but it's a phenomenon that became more clear as the programs progress towards the eradication of guinea worm. So now you have a zoonotic component. So sometimes these zoonotic components threatened our goals. So in 2019, just prior to the launching of the NTD roadmap, the WHO and particularly the Department of NTD Control launched a consultation process with the NTD community, and mathematical modelers were included in that consultation. A series of papers was published in Gates Open Research. In our particular case, the NTD Modeling Consortium, under which umbrella we conducted this work, is funded by the Bill and Melinda Gates Foundation. But if you look at this Gates Open Research collection, it involves a collection by many other contributors, not only the NTD Modeling Consortium. So in particular, our groups looked at the insights and quantitative insights and quantitative predictions or projections from mathematical modeling for Chagas disease, and that version is approved. You can always check if there are updates in an open letter. Also, the same applied for Taenia solium, taeniasis, cysticercosis, and that version was also approved, and you can check for updates. And then another one for onchocerciasis. So we are going to check these 3 ones, but as I say, there are many more that you can have a look. After that, after actually the publication of the roadmap, there was this all-encompassing paper, how modeling can help steer the course set by the roadmap. And that again is an approved version of this open letter in which various people, partly part of the NTD Modeling Consortium, but not all, part of the NTD Modeling Consortium contributed to this publication. Now, we also recognized early during this process that we also needed to have a very clear reporting system when we are modeling for policy in the neglected tropical disease area. So we knew that for systematic reviews, etc., we had the PRISMA guidelines. So we came with something called the PRIME guidelines, which are the items that we want to report prime NTD for the neglected tropical diseases. So we distilled 5 main principles to guide our work, and that was published in PLOS NTDs. The first principle is engage your stakeholders throughout the process. And as Mutono and Zumbi well know, this is something we try to do with the NTD Modeling Consortium, and our stakeholders can be our funders, can be the World Health Organization, can be program managers, can be country programs, and we would like to engage them into the formulation of those questions, and also how the questions that are raised can be formulated in a way that you can address them through modeling. Then also the idea of reproducibility, that once you start doing this work, you need, one, to have open access repositories and GitHub, for instance, of your model code, that there must be a complete technical documentation of your model code, so it is reproducible, it is accessible to others, but also is updated, because models also is like a living systematic review. Models are also a living entity. You are always improving them, refining them, increasing their ability to model different outcomes. By the same token, data are very important, and access to data, data curation, data collation, and all the data you need for calibration of the model, parameterization of the model, fitting the model to data, or validating the model should be described in sufficient detail in our publications. And hopefully with, if it's possible, with country permission, those data should also be available. This is a more difficult area sometimes, because sometimes countries do not necessarily make their data available. But for instance, in terms of data, both EDO, the Infectious Disease Data Observatory at the University of Oxford, but also ESPEN, the ESPEN portal. ESPEN stands for the Expanded Special Project for Elimination of Neglected Tropical Diseases in the Afro region, is very keen to make sure that data are publicly available. Now, models are not crystal balls, so we cannot predict the future. We can forecast, we can communicate our projections, but we also have a responsibility to communicate the uncertainty that surrounds our projections in terms of prediction intervals, in terms of sensitivity analysis. So communicating uncertainty, communicating not only the magnitude of uncertainty, but an appreciation of uncertainty is very important. And also, as far as we can, as much as we can, produce model outcomes that become testable hypotheses. So if I make a projection about infection trend, prevalence, intensity, transmission, etc., I hope that data will be coming available with which I can test those projections. So let's start with Chagas disease. Chagas disease is mainly endemic in Latin American countries, but with increased immigration, for instance, into Europe, there are many cases of Chagas disease also in Europe. Not necessarily the vectors, but cases do exist. So as we discussed before, the target is elimination as a public health problem. We want to interrupt the intradomiciliary transmission by vectors, eliminate blood transfusion-related transmission, and transplantation-related transmission, and congenital transmission. So for this endeavor, and throughout the PhD of one of my students, who is now back in Colombia, we developed, with the support of the Pan American Health Organization, a platform called the DICTUM platform, which stands for Decreasing the Impact of Chagas Disease Through Modeling. And the DICTUM platform is geared to collect seroprevalence data, transmission data, vector data with a number of countries in Latin America that have engaged with the platform. Colombia being, say, the flagship, but also Chile, Paraguay, now Brazil also wants to be on board. Can we achieve these targets? Now, if we cannot achieve these targets, what would be required? So that's what takes us to the complementary strategies. So we know vector control, a vector control strategy has been deployed. But if we could combine vector control with, say, annual trypanocidal treatment, and I'll show you some simulations, in 10% of the infected human population. So perhaps in the infected human population, perhaps not only in terms of acute Chagas, this is a case of acute Chagas, for instance, this is where the this person would have had a bag. These are the cone nose bags, and maybe a bite, and then it would have scratched its eye, and then with that introduce the feces of the because it's through the feces, not through the bite, into the conjunctiva, for instance. Now, one important thing here is the access to diagnosis and treatment, which is very, very low. What type of models have been used? Well, in this case, we have used force of infection models, because with the force of infection models, we can look at the age stratified seroprevalence, but also then we can link these force of infection models with disease burden models, and then try to understand what is the potential need for other interventions. Chagas develops over a long period of time. And although this is acute Chagas, this is more kind of chronic Chagas. So you can have myocardiopathy, which is heart disease. You can also have megacolon. So these conditions develop over many years. And then people are going to need support for heart disease. So we need to plan in advance, because it will develop in many years in the future. So this is an example of these simulations I was talking about. So our goal here was to look at the number of years that would be required to reduce seroprevalence for Chagas disease in the under 5s to less than 2%. And that was like a sort of operational threshold. And low endemicity, moderate endemicity, high and very high endemicity settings were modeled through increasing the vector density, in this case, the vector to host ratio. So on the y-axis, we have a proportion of parasitological cure, meaning if we could treat individuals, we could treat people in the population, and we could achieve, say, between 0 and 40% parasitological cure. And on the x-axis is vector control, as in if we could reduce vector density here between 0 and, say, more than 80%. And here you have your scale of years. So you can see that for areas of low endemicity, you can reduce, say, your number of years by a good amount in this area with, you could say, moderate levels of vector control, perhaps. And you could also moderate levels of the parasitological cure. Of course, as you reduce your proportion of parasitological cure and your vector control efficacy, you increase the number of years that would be necessary to achieve those thresholds. But by contrast, if you look at an area of very high endemicity with very high vector density, then we would need a much higher efficacy of vector control. You would need to basically have at least a 90% reduction in your biting density, although it's not by biting, but in vector density, because the vectors do bite and then at the same time excrete, and the parasite is transmitted through the vector feces, but also a very high or much high proportion of parasitological cure. So you are in these areas. Otherwise, you are in the red area, in which you would need many years to achieve your goal. So this is an example of an alternative or complementary strategy, rather, because what you would like is to complement your vector control strategies with treatment. And in this case, with the force of infection models, for Colombia, we were looking at the data, serological data from the early 19th to, in this case, to 2014, and see how the force of infection would have decreased in the country. And in this issue, in this volume of the Philosophical Transactions of the Royal Society Series B that I mentioned, there is a more complete paper for Colombia, taking the pipeline from serological surveys to burden of disease, expanding this work. Now, for taeniasis, Taenia solium taeniasis cysticercosis, we developed a model that we called EpiCyst. At this moment in time, this is a deterministic model. Taenia solium is a zoonotic infection, and pigs are the intermediate host. Now, the problem is that humans can also act as accidental intermediate hosts. So if humans consume poorly cooked pig meat, humans are going to become the definitive hosts harboring the adult Taenia. But because Taenia then produces eggs, if humans are infected with eggs, it could be through poor hygiene practices, then humans also become these accidental intermediate hosts. And then we can have, for instance, this, instead of having these cysts that you can see here in the muscle of pigs, some cysts can lodge in the brain, and that leads to the condition that we call cysticercosis. And this condition can lead to epilepsy. And obviously, epilepsy has excess mortality associated with it. So as we saw earlier, endemic countries with intensified control in hyperendemic areas. So what is the extent of these hyperendemic areas? That has not yet been delineated. Can modeling inform what could be the complementary intervention strategies? Also, we don't have great serological tools to measure the prevalence of taeniasis or even porcine cysticercosis. So the long-term sustainability of some of the interventions is still uncertain. But let's look here at some modeling. So what is our target? In this case, it's a number of years to reduce Taenia solium porcine cysticercosis prevalence. And we chose 3 prevalence targets. Now, again, this is speculative because this has not been, there are no guidelines for what these prevalence targets could be. But informed by all the diseases in the roadmap, we chose, say, less than 1% of porcine cysticercosis prevalence. That would be quite a stringent target. Less than 5%, a moderate target, or less than 10% as a more lenient target. And also with vary the pig slaughter's age. And the reason for that is that the later the pigs are slaughtered for consumption, the greater is the chance that they will have acquired infection. And they acquire infection, by eating eggs, which are excreted with the feces. And sometimes the dominant pigs, the alpha male pigs, are the ones who have a feast on human feces. So let's look at that. So what do we vary here? So on the y-axis, we are varying the coverage. You can see here from 50% to 100%. Here we vary the minimum age from which pigs are slaughtered, 18 months. And what are the strategies we are comparing? If we can only do pig MDA, so we still can treat the pigs with mass drug administration, with a drug called oxfendazole, and in this case, every 3 months. So that will be quarterly frequency. Or we could vaccinate pigs with Taenia solium. T-sol 18 is one of the most effective vaccines. So with T-sol 18, again, 3 monthly. Could we combine pig MDA and vaccination? Again, 3 monthly. And for this comparison, or treat humans with praziquantel, and we use the same frequency for the sake of comparison. So yes, praziquantel is used in MDA for Taenia solium. Praziquantel is also used for MDA in schistosomiasis. And it's interesting because in some areas, schistosomiasis and taeniasis are co-endemic. There are some risks of treating with praziquantel because it could lead to rupture of cysts and perhaps some exacerbation of the neurocysticercosis. But some countries have implemented NDA with praziquantel in the human population. So let's have a look at the most stringent target here. And here you have the time to reach this target. So the yellow indicates, say, less than 1 year, and the dark blue will indicate more than 9 years. And the green will indicate about 5 years. So if our coverage is very low, obviously, we have for nearly all of the pigs slaughter, maybe slightly less if pigs were slaughtered very young, but we here are in the area of dark blue and green. So it's a very stringent, target. So if we do pig MDA, we may get somewhere in the very long term. But in this case, our models suggest that only vaccination, we don't get anywhere with only vaccination. But if we could combine vaccination and MDA, then things are looking a little bit better. I was going to say a little rosier, but I possibly mean a little greener. And here again, for instance, you can see this, if you have a high coverage and you can reduce the age of slaughter of pigs, you might be in this area. But it becomes better and better, obviously, if the targets are more lenient. Now, with human treatment only is not great, because human treatment only for all of these pig slaughter ages, we don't get anywhere. And if we can decrease the age and increase the coverage, we are still in the dark green. So this is a paper with Matt Dixon. At the time was my PhD student, and now he's our postdoc for the NTD modeling consortium working on onchocerciasis. So this paper is, we need to finish this paper. But what does this all mean? Well, what is intensified control? Is intensified control less than 1% of porcine cysticercosis prevalence, or less than 5%? That hasn't been defined. And that is, and in which areas? Because obviously the different areas will have different endemicities. And he has also done some work to define the endemicity based on seroprevalence in pigs and in humans. So I'm now going to move to onchocerciasis. So for onchocerciasis, we have a variety of models. EpiOnco is a deterministic model. EpiOnco IBM is the individual-based model version of this model. And we also have a SymPop model, which is a population dynamics of the simulium vectors that we can combine if we want to look at vector control. So we are assuming it's an anthroponotic infection. So I think I said that taeniasis cysticercosis is obviously zoonotic with pigs, but also Chagas disease is very zoonotic. So in this case, we have an anthroponotic infection, a vector-borne disease, and simulium black flies are the vectors. So in this case, at that time of the consultation, verified EOT was going to be in 10 countries, and then this was changed to 12 countries. But it's the verification of elimination of transmission, as we discussed. So what our models said at the time of this open Gates letter, and I don't think we have changed much from this, that elimination of transmission can be feasible. We think it's feasible in areas of low to moderate endemicity. But when we have areas of hyper and hollow endemicity, or areas where MDA has not yet started, or is young, it's a young program, then that is going to be more difficult. So, for instance, with Mutono and Thumbi, we have conducted a systematic review of the literature that more or less confirms these predictions here, these projections here. For example, in the area of South Sudan, MDA is still weak and still young. So we have perhaps better data from some countries. Now, I will go into the examples of vector control, because also in some of these countries, vector control had been implemented or vector disappearance, but not in all. I cannot abound in all of those, but we can discuss them in the discussion. So if we can't achieve with ivermectin, which is the drug of used now for community-directed treatment, CDTI, community-directed treatment with ivermectin, what other tools? So biannual treatment, for instance, we have also modeled biannual treatment, obviously under some assumptions, or quarterly, that again, that would be every 3 months, or the use of moxidectin, vector control, anti-Wolbachia therapies. What is this anti-Wolbachia therapy? So this is a figure here, an illustration of the adult worms in a mass of in the nodules. This is extracted from the palpable nodules. Now, Onchocerca volvulus harbors an endosymbiotic bacteria called Wolbachia pipientis. If you treat with anti-Wolbachia, meaning antibiotics, some antibiotics, for instance, doxycycline, for a prolonged treatment course, then you can deplete the Wolbachia bacteria from the adult worms, and that can lead to sterilization and excess mortality of the adult worms. So you could look at a drug which has macrophyllaricidal properties. When I say macro, it's because I'm talking to the large macrofilaria, the adult filaria. Now, ivermectin has microphyllaricidal properties, meaning that we are mostly killing the microfilaria, which are the embryonic stages, the larvae produced by the adult worms. So, what are the biggest risks? What are the risks that need to be mitigated? That EOT may not be feasible with current tools in areas of high endemicity, that we could have resurgence if MDA is stopped prematurely. And that is very important that we understand when we really can conduct the stop MDA surveillance and the surveillance. Population movement between communities can also be a risk. One other risk here is the coendemicity with loiasis. So here, this is a map of the former OCP area, the onchocerciasis control program in West Africa. And this is a map produced by geostatistical modeling of the prevalence at pre-control before the interventions that took place in the OCP, which were initially vector control and then mass drug administration of ivermectin. The intensity of the color, of course, here in this scale relates to the intensity the intensity of the color relates to the highest prevalence areas. And this piece of geostatistical modeling was conducted by my then PhD student, Simon O'Hanlon. Here we have a similar geostatistical model, but instead of being based on microfilaria prevalence, as this was based on nodule prevalence. The nodules, as I explained earlier, are, well, the name indicates they are like protuberances, if you want to call it like tumorations that are palpable in some cases, and within those nodules, the adult worms live and the adult worms reproduce. So this is a rapid epidemiological assessment method because you can rapidly, in relatively small samples of adults, look at the prevalence of nodules, and using that prevalence, this came about as the geostatistical map with the same idea that the intensity of color here tells you what are the areas of highest endemicity. But if you look at a map for Loa Loa based on another rapid epidemiological assessment method called the RAPLOA. The RAPLOA is history of eye worm because Loa Loa can pass through the eye and be visible, and people can report on the history of eye worm. And you can see the vector here is a tabanid fly. different from the black flies. But you can see that there are areas of overlap. So I have more or less aligned this map. So you can see them, for instance, here in Cameroon, in this area of Cameroon, here in the southwest province in the south, and most of this area is co-endemic with Loa. So in the north, you are okay. This is the extreme north province. This is the north province. And then there are some center regions in which onchocerciasis can be very intense, but you don't have Loa. But in the lower half, you have coendemicity with Loa. Another area of concern here is the DRC, the Democratic Republic of Congo, in which these areas of high onchocerciasis endemicity also overlap with Loa. Now, you can't really apply CDTI, the community-directed treatment with ivermectin, without thinking what you're doing, either because you need, for instance, it has been proposed that in areas of high endemicity of onchocerciasis, you still do CDTI, but you do a lot of pharmacovigilance, you look at side effects. I'm not necessarily in agreement with that strategy for the reasons I'm going to explain. But in the areas that are hypoendemic with onco and there is a high risk of LOA, then you do not apply MDA because individuals who are co-infected with onchocerca and LOA, say, they don't necessarily have to be co-infected, but living in co-endemic areas and have a high LOA microfilariemia, if treated with ivermectin, they can develop severe adverse events that include encephalopathies and that include fatalities. I mean, people can die after ivermectin treatment if they have high levels of LOA infection in their blood. The reason I have some qualms about whether in areas that are co-endemic with LOA but highly endemic for onco, you should treat MDA with MDA is that you still have to have that risk. The idea is that the benefits outweigh the risk, but you should be so vigilant that people treated with ivermectin are followed up. But what do you do, really, if people develop severe adverse events? So the result of this dilemma and this situation in which the communities themselves find is that if you look at some areas of Cameroon, like the southwest province and something in the littoral province, etc., adherence to treatment to ivermectin is very low. And it's very low either because people have fear of side effects, have family or neighbors that have experienced these side effects if they were co-infected with LOA or have died. And even if the transmission of LOA is much lower, then there is this still communication between villages and between communities. And treatment adherence in the co-endemic areas can be very low. So it's a real problem to achieve elimination in some of these areas. Now, to understand what our models do, we also need to understand that there is a very non-linear relationship, in this case, between microfilaria prevalence and the annual biting rate. The annual biting rate will be the number of bites per person per year by the black flies. And this is microfilaria prevalence, which is, as I said, the larval progeny of the adult worms. You can see here, for instance, this is some person excising a palpable nodule. That's where the adult worms live. But this is all based on microfilaria rather than adult worms. So because we have this very non-linear relationship, and this is the whole model, the whole of the Epionco IBM model fitted to this data, you can see here that the biting rates, as you have this biting rate here, as if you increase your biting rate, say, from 25,000 or more, you already have very high levels of endemicity and also of microfilaria. So even if you are going to do vector control, which we are going to discuss in a minute, you would need to reduce your vector density by a lot and for a long time to be able to reduce your prevalence. So one thing I should say is that the adult worms of onchocerciasis live on average for 10 years. They're very long-lived. And if ivermectin is predominantly microfilaricidal and perhaps less macrofilaricidal, although that is an open question as well, then we need macrofilaricides or we need very prolonged interventions. If we were going to plot the biting rates for different endemicity levels, in this case, annual biting rate, say, in this case, is for a hyperendemic situation. And you can see here that you can have hyperendemicity in this case from 5,000 to 20,000, like I showed in the previous slide. And this is only annual ivermectin. Then the group of villages in which you can eliminate, you can still see something, but it's very, very, very low. So that would correspond to much lower biting rates. If you could do biannual CDTI, you start increasing the range of biting rates for which you could eliminate. And here, for instance, you could get up to maybe at a push at 10,000. With annual moxidectin, the results are similar, in this case, to biannual ivermectin. But the results with biannual moxidectin seem to expand this range of biting rates much more. And then here we have nearly 20,000 in some communities in which our simulations predict we can eliminate. So this is obviously all in silico, but the idea is that maybe vector control combined with moxidectin could help. Now, why is moxidectin better than ivermectin? So there were some clinical trials, phase 2, RCT, phase 3, RCT, randomized clinical trials. The control in this case was ivermectin. These are the results of the dynamics of microfilaria after single treatment. So you can see here your pre-control level, and then once ivermectin is given, you have quite a big reduction in your microfilaria load. And then, because there is some embryostatic effect, there is a reduction in the production of microfilaria by adult worms, but then adult worms resume their microfilarial production, and you have skin repopulation in the ivermectin arm. And here in the moxidectin, you can see that this repopulation is a lot slower. So here, for instance, for about a year, you still have a lot of people who do not have high levels of microfilaria in their skin, as opposed to those in the ivermectin arm. In the phase 3 clinical trial, the results were very similar, with higher repopulation rates for ivermectin and much more prolonged suppression of skin microfilaria for moxidectin. So what we did in our models were to parameterize our efficacy parameters for ivermectin and moxidectin based on this clinical trial data. So based on that, we then also looked at the worst case scenario. The worst case scenario are the hyperendemic scenarios. Because in the hypoendemic scenarios, you could say, well, do I really need moxidectin? Yeah, it would accelerate, of course, but it's in the hyperendemic scenarios which are in trouble. So according to this hyperendemic scenario and sampling biting rates, only annual CDTI is not going to take us to elimination. Our probabilities of elimination are going to be very low or even nil. With biannual CDTI, which is this, we do a lot better. With annual moxidectin, we do better, but the best thing we could do, according to our simulation results, is to do biannual moxidectin. And if we could do biannual moxidectin, well, here, even with minimal coverage of 65% of total population, which is approximately 80% of eligible population, according to this, we could achieve 90% probability of elimination in a reasonable time frame. Of course, these are in silico simulations, so there has not been any treatment prior to this. You can also do simulations in which you simulate prior history of treatment and then you introduce moxidectin. But if you could enhance coverage, and this case is 80% of total population, then also you can do better with annual moxidectin, but you can even do much better with biannual moxidectin. Now, the problem with this is that when we look at minimal coverage and enhanced coverage and 65% and 80%, we also need to look at adherence. And I'm not going to show these results because they are just being generated as we speak. But the higher the proportion of systematic non-adherers, either because they refuse treatment or because there is some correlation structure in the adherence to treatment, then we are going to have much less positive results than this. Now, that doesn't mean moxidectin is not a good drug, but it means that you really need to understand your coverage and adherence, minimize your systematic non-adherence, and hopefully increase your coverage. What about vector control? So there has been a lot of interest in something called slash and clear. It's not practicable everywhere, but it's a non-chemical method for vector control in which the individuals in the community, so it could be a community-directed method as well, can remove the vegetation. You can see here that to this vegetation is where the larvae and the pupae of the Simulium flies attach. So if you remove the vegetation, you could remove the breeding sites. It does need quite a lot of training and the removal of the vegetation. The vegetation will grow up, so it needs to be done more regularly. This is the head of the larvae of Simulium. So this in the immature stages, they are filter feeders. These fans here act in the filter feeding. These are aquatic, whereas the adult stages are aerial, and this is a female. Only females imbibe or, well, take blood meals. So this is a long-term trial data in northern Uganda. And one of our MSc students, but based in France, simulated this. One of the important things was, in this case, was only one slash and clear cycle. And then because of seasonal issues, also we have variation, which is due to the intervention, but also to the seasonal variation. So in this case, we can see, for instance, the green here is the seasonal variation, natural variation, and the yellow is the intervention impact having accounted for seasonal variation. So you can still see that it reduces beyond the seasonal variation. So you can model however many cycles you would need. This was just one cycle, but you cannot just do slash and clear for one cycle per year. Maybe you need 2 or 3, maybe you need it, say, here and here and here, and then for a number of years, because if your biting rates are very large, as I explained earlier, then if they are going to bounce back, and if they bounce back again to those high biting rates, you have not decreased transmission. So you really need to model this properly to understand what the countries should implement. Now, if we look at some macrophyllary site simulations, so here, for instance, we have, these are probabilities of elimination with ivermectin only in a mesoendemic setting, with a macrophyllaricidal only drug, what we call MOM, macrophyllaricidal only medication. If we could also combine it in lower, non-lower areas, macrophyllaricidal and microphyllaricidal medication, so like a dual action, or an able and anti-Wolbachia therapy. So we could look at the probabilities of elimination in 2 different endemic settings. This is a mesoendemic. This is a much higher holoendemic setting. This setting had a number of years of ivermectin treatment, and then we can introduce these alternative strategies. So with the NTD modeling consortium, we've been embarking in looking at some of these alternative treatment strategies. And this is for the so-called endgame project. So this is in the area of the OCP and in the area of APOC that you saw previously. So this is based on the geostatistical map based on microfilarial prevalence, and this is based on the geostatistical map, which was based on nodule prevalence, and we parameterized this with EpiOnco IBM for annual biting rates of the vectors, but also for exposure heterogeneity. So you can see in this case that the exposure heterogeneity tends to be quite low and tends to be, in this case, at about 0.3, which is one of our model parameters. And then you can see the prevalence, again, the intensity in the high prevalence areas here and there. So now we could simulate treatment and NDA, so and a drug efficacy. So they call it an egg reduction rate, but that's not applicable to us. But in a sense, what we really want to be looking at here is the rates in microfilaria prevalence. So for instance, you could say ivermectin at 65% coverage. So this is kind of the minimal coverage, annual frequency with 5% of systematic non-adherence. Or you could look at ivermectin now with an 80% coverage, biannual treatment, and a 1% of systematic non-adherence. Or you could have ivermectin 4 times per year, or you could have ivermectin 4 times per year with increased coverage, or you could have moxidectin with 80% coverage and biannual, which was our best case scenario, or you could have a macrophyllaricidal drug, a macrophil, maybe with a, say in this case, a lower coverage. So this line here, this is for the OCP implementation units that they had the highest prevalence at 2022. And that was thinning to the 1% with the highest prevalence. And then you can see that business as usual does not really, I mean, reduces the prevalence, but it doesn't reduce it sufficiently. So the intervention of the other strategies does a lot better. And the better here is the 3B and 3A, with the 3A being ivermectin 4 times per year, and the 3A, sorry, 3A ivermectin and 3B moxidectin biannually. So it seems that in this case, moxidectin biannually could be as good as ivermectin quarterly. Ivermectin quarterly has been used in Mexico and is being used in Ethiopia in some areas of the Carter Center assisted projects. So it's not totally pie in the sky, but to implement 4 times per year MDA would be more difficult than biannual moxidectin. And that will be with the highest prevalence, and also this would be with the lowest prevalence here when they enter in 2022. So again, we think, for instance, that these strategies in those implementation units with the lowest prevalence could lead to elimination. So this is the end slide. The importance of understanding the 3 foundational pillars, and that the acceleration of programmatic action necessitates of the alternative and complementary treatment strategies. Yes, the cost-cutting approaches. So, for instance, for Taenia solium, we saw we would need intersectoral collaboration and veterinary health as well to tackle the problem in the pig population. The importance of promoting and enhancing country engagement and ownership. That we were able to contribute to the consultation process with mathematical modeling. That also we became very aware that we need to report the results of our modeling in a way which is very transparent to our readers, following the 5 principles of the NTD modeling consortium. And what and this is a continuous dialogue. This has an end here. What is the technical feasibility of achieving these goals? Can we identify the challenges and opportunities? And obviously through that, we are also engaged in a business case for moxidectin and in the modeling, hopefully, of other strategies.